everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance, and I'm very pleased again to welcome Dr. David Reznik, who will share with us the newest updates on the pandemic.
Thanks, Gary, and as always, it's truly a pleasure to be with you, going over some of the latest findings that we've had as far as COVID, some of the manifestations that we're seeing in children, where we are with the epidemic in the United States and elsewhere, and then discuss really something that is dear to my heart, which is that dentistry is essential care. And we're going to go into that a little bit in today's talk. So, look at the number of distributions and COVID hotspots in counties around the United States. It truly has been a roller coaster. When we first started during March 8th to July 15th, 818 counties met the hotspot criteria for greater than 1 day. These counties included 80% of the United States population. I want to repeat that, 80% of the United States population. The daily number of counties meeting hotspot criteria peaked in early April, decreased and stabilized during mid-April, early June, and then increased again during late June and early July. And that's the roller coaster that we've been on. We sort of thought we had a bit under control, and then we came back. The percentage of counties in the South and West Census region meeting the hotspot criteria increased from 10 and 13% respectively during the March to April timeframe to 28 and 22% respectively during June and July. So you can see there was a shift that I'll show you on some graphs in a few moments when we had our initial outbreaks in the Northeast and out West, and then all of a sudden it hit real hard in the Southeast and the Sun Belt area, and now that's beginning to wane to a degree. Identification of community transmission as a contributing factor did increase over time, whereas identification of outbreaks in long-term care facilities, food processing facilities, correctional facilities, or other workplaces as contributing factors have decreased. So that's good to know. And as of now, there are no clinical transmission to documented clinical transmission from a patient to a dental healthcare worker, which is always encouraging. And that's because of the wonderful PPE that we have and the equipment that we can use to decrease the risk factors. So here is a look at the trends in number and distribution of the hotspot counties that I was talking about. The first top chart A, from March 8th through April 30th, if you look real closely, you'll see the little yellow dots on there. There are 1 to 7 days that they had a problem, and as the dots get darker, then they had hotspots for a longer period of time. So the really big dark hotspot, like you can see in New York, that was greater than 29 days. Then, if you look from May, my birth month, you can see that actually it looked like things began to calm down. We saw less places, but still there's counties that have impacted all throughout the United States. On our figure 2, what you can see on the top of your screen is June 1 through July 15th. And you can see, compared to where we were on the previous slide, we have a good deal more areas that have at least 1 to 7 days. Those are the light yellow, and then greater than 29 days. And you can see how hard the state of Florida was hit, parts of Texas, Arizona, parts of California. And you can see that it sort of subsided up in the Northeast. So this virus tends to come and go, as we've been seeing. If you look at the last map, the bottom map, that is actually from March 8th through July 15th. So you can see the parts of the country that have been hit the hardest. This is really important for us to keep up with. We really need to know how the epidemic is in our county or in our state, but specifically our county or our region, so we know what the relative risk value is. So I think we really need to keep eyes. Like you know, Georgia has been suffering recently, and we'll talk about that in a moment. Here is just a graph that shows you the trends. So if you look at the metro area, which is the line, and the first area, the 8 to 29, that is March. The next area would be April, then May, then June, and then the 5 and 12th is July. And you can see that during June and July, beginning parts of July, we saw a rapid increase in metro areas and micropolitan areas, medium metro areas, etc. So we sort of hit the same level that we were at one point, and now we're actually increasing. We're doing more testing, which is one of the reasons we have more cases, and we also follow it by hospitalizations. And I'm very close to that since I work at a hospital, and I know that we're still seeing a significant number of cases in Atlanta. Speaking of Atlanta, in Georgia, where several districts reopened in recent weeks, more than 1,000 students and staff were asked to quarantine following cases of coronavirus or exposure to someone who was infected. Regretfully and very sadly, a 15-year-old boy from the Atlanta area became the second youngest person to die from COVID-19 in Georgia. And this is according to our Department of Public Health. Earlier this month, again, regretfully, a 7-year-old boy from Savannah passed away. These are losses that are really, truly, all losses are remarkably hard to get over. So we look at the hospitalization rates and characteristics of children less than 18. We hear that there's a lot of infections in our youth these days, but it's not as severe. So really, what do we know about the topic? Well, most COVID-19 infections in children less than 18 are asymptomatic or mild, so that is really good news. What we don't know as much about, and what we're really trying to concentrate on, is severe COVID-19 in children requiring hospitalization. What more can we learn from that? This report that was a CDC MMWR looked at the analysis of pediatric COVID-19 hospitalization data from 14 states that found out although the cumulative rate of COVID-19 associated hospitalizations amongst children, which was 8 per 100,000 population, is considerably lower than that in adults, which is 164.5 per 100,000 population. However, 1 in 3 hospitalized children was admitted to an intensive care unit. So protecting our children by masking and doing all the things that we're doing these days is truly important. Children are at risk for severe COVID-19, although not as much as adults. Public health authorities and clinicians, including dentists and dental hygienists, our staff, should look and make sure that we're tracking our pediatric infections and seeing if it's in our neighborhoods, in our communities, because we have wonderful pediatric practices. We really need to reinforce prevention efforts. All you have to do is turn on this TV and you can see college kids all getting together. You can see youth getting together. And this is a normal behavior. A lot of people have been home alone for some time. This is not a blame game. This is just a reality check that when you go to college, you're set free for the first time in many people's lives, and that we run into some issues. Specifically, North Carolina, University of North Carolina, which is a tremendous school, is now basically doing only online for a few weeks. So there's plenty of implications to monitoring this disease outbreak in our children. Moving on to people who have recovered from COVID-19, there was an article in the Journal of the American Medical Association that I thought I would share with you. Almost 90% of patients who recovered from COVID-19 reported at least one persistent symptom. And this included 143 patients. So this was not a small study. This was actually a pretty significant study. During their hospitalizations, about 73% of the patients showed symptoms of pneumonia. The average patient age was 56, not greater than 65. The average patient age, 56. The average length of stay was 13.5 days. Again, from someone who works in a hospital, that is a very long length of stay. We want our length of stays to be short. That's how hospitals get reimbursed. And 13.5 would normally be something that we might see with one of my traditional patients, and a person with uncontrolled HIV being in the hospital. A total of 15% of the patients underwent non-invasive ventilation and 5% had invasive ventilation. The researchers analyzed patients on average of 60 days after the onset of their symptoms, so quite some time. Only 12.6%, less than 13% of patients had no symptoms at the time of this evaluation, which is remarkable. The remaining 87.4% reported symptoms. 32% reported one or two symptoms. 55% showed three or more symptoms. Interestingly enough, no participant showed fever or signs of acute COVID-19. Almost half, 44%, of patients reported a lower quality of life following COVID-19. I say this and I bring this up with the main purpose of it's so important, even when we get tired, to wear our masks when we're not in the dental setting, to wash our hands proper and watch for other people and stay physically distant so we can get this under control and move on to a more normal level of life. And speaking of that, we actually have some good news. You know, I like to focus on the good news, not so much the bad news. And this is a very important study or set of studies that scientists are beginning to see lasting signs of immunity to COVID-19, even after mild infections. And so, focusing on the positive, we see that new research indicates that the human immune system cells are storing information about coronavirus so they can fight it off again. So this is more than just the antibodies. Researchers have yet to find unambiguous evidence that coronavirus reinfections are occurring. And I think that's remarkably important. So people might have symptoms like I just talked about, but they're not really getting reinfected, especially within the few months that the virus has been marching through the human population. I mean, we've actually seen this go through a significant part of America, and we have yet to really have any documented cases of reinfection. So how is that happening? Well, disease-fighting antibodies, as well as immune cells, and their B cells and T cells, and actually part of my normal work in HIV, they can recognize the virus, appear to persist months after infections have resolved, an encouraging echo that the body's enduring response to other virus. So it looks like we might have some pre-existing immunity, at least some of us. Antibodies represent just one wing of the complex and coordinated squadron of immune soldiers. This is actually taken out of the New York Times. I'm using their language here. Each with their own unique modes of attack. Viruses that have already invaded cells, for instance, are cloaked from antibodies, so antibodies don't work. But they're still vulnerable to killer T cells, which force infected cells to self-destruct. So even if the antibodies don't get you protection for a long time, your other immune system, your B cells and your T cells, have an important role. Another set of T cells, named the T cell helpers, can coax B cells to mature into antibody-making machines. So we do have another portion of our immune system that is helping to protect us. And what's also important is we have not seen reinfection, but we have seen some persistence in symptoms, and I think that we need to sort of put into our equation. Mild cases of coronavirus can trigger robust memory T cell responses, even in the absence of detectable virus-specific antibody responses. And this was reported in August 15th in the Journal of Cell. The authors say that memory T cell responses generated by natural exposure to an infection or severe acute respiratory syndrome, coronavirus or SARS-CoV-2, may be a significant immune component to prevent recurrent episodes of severe disease. Again, this is good news. It was published in Medical Express this month. Again, something positive to look forward to. Then again, when we look at our hospital air, when we look at our clinic air, we need to be realistic about what this aerosolization is. So a research team out of the University of Florida, where my brothers graduated from, succeeded in isolating live virus from aerosols collected at a distance of 7 to 16 feet, much more than the 6 feet for physical separation. So the distance of being 7 to 16 feet from patients hospitalized with COVID-19. So again, this is a little bit of a difference in a clinic environment. That's why we want to increase our air exchange rates. We want to use extraoral devices. We want to put in different kinds of HEPA filters or different kind of filtration that we've covered in the past to make sure that if there is circulating virus, that we're either killing it with a one-pass system or we're making sure that it goes out into the air. So the findings from this study, the virus was isolated from air samples collected up to the 16, 17 feet away from patients. The genome sequence of the SARS-CoV-2 strain isolated from the material collected by the air samplers was identical to that isolated from the nasopharyngeal swab from the patient with the active infection. So what do we know from this? Patients with respiratory manifestations of COVID-19 produce aerosols in the absence of aerosol-generating procedures that contain viable SARS-CoV-2. And these aerosols may serve as a source of transmission of the virus. So that is very important while we're in the dental office. When we're with our patients, we have on our N95s. When we're not with the patient or you're still in the clinic setting, keep on your N95s or at least put on a level 1 or 2 surgical mask. And when you're out in public, masking, if you're inside a grocery store, you're inside whatever kind of store, make sure that you stay masked, that you have hand sanitizer, and that you protect you and your families. I always say that my most important job is protecting the health and well-being of my staff and my patients, and this is also for those, to me, my most important job is communicating how important taking care of yourself during this epidemic or this pandemic is. So we've had the American Dental Association, their board adopted a new interim policy on dentistry as essential health care. For me, this should not be an interim policy. Dentistry is always essential health care. I've worked in HIV disease since the 80s, where up to 93% of patients would present with some kind of oral manifestation. We were diagnosing people or letting people know at risk based on what we would see in their mouth, whether they had candidiasis or Kaposi's sarcoma. So we've always been an integral part of HIV care. And I'm so happy to see the association say that dentistry is essential healthcare for all people. And so what did? The American Dental Association adopted an ad interim policy stating that dentistry is essential health care. And this is to help guide advocacy for the dental profession during the COVID-19 pandemic and beyond. The substance of this ad interim policy was developed by the Council on Dental Practice, and the House of Delegates will consider it as a resolution during the virtual meeting in October. So this is good news. What is this policy? And it really is extraordinarily well done. Resolved that the policy, dentistry is essential health care, be adopted on an ad interim basis to guide advocacy for the profession during the pandemic. 1. Oral health is an integral component of systemic health, without doubt. Dentistry is an essential healthcare service because of its role in evaluating, diagnosing, preventing, or treating oral diseases which can affect systemic health. The term essential dental care can be defined as any care that prevents and eliminates infection, preserves the structure and function of teeth as well as the orofacial hard and soft tissues, and that this term be used in lieu of the terms emergency dental care and elective dental care when communicating with legislators, regulators, policymakers, and the media in defining dental care that should continue to be delivered during global pandemics or other disaster situations if any limitations are proposed. So again, this is just saying what we do is essential to people's health. And we've known that as a part of the profession since we all entered this profession. The fourth point of this ad interim guideline is government agencies such as the Department of Homeland Security and the Federal Emergency Management Agency have acknowledged dentistry as an essential service needed to maintain the health of Americans so they can sustain their health and livelihoods and live resiliently during the COVID-19 pandemic response. State agencies or officials be urged to recognize the oral health workforce when designated as essential workforce during public health emergencies in order to assist them in protecting the health of their constituents. This was from the American Dental Association Board of Trustees in July of 2020. Resiliency is a huge area for all of us now. We've been stressed by maybe losing loved ones, or our practices have been significantly harmed by this pandemic and how it's been managed in the past, but we have remarkable PPE now. We have remarkable tools that can allow us to provide the safest dental visit. Dental care is essential to healthcare, and we need to make sure that we advocate for that as we move forward. So why did the American Dental Association, adopt this policy besides my commentary? As COVID-19 cases continue to rise in many states, governors may consider rolling back to an earlier stage in their COVID-19 response strategy. If that happens, there may be a risk that dental practice will be told to perform only emergency or urgent procedures. The American Dental Association Board, and I believe this would be a disservice to the public, the ad interim policy states oral health is an integral component of systemic health, and dentistry is an essential healthcare service because of its role in evaluating, diagnosing, preventing, and treating oral diseases. So dentistry is essential health care. We can look at the mouth-body connection, and I know that as dental healthcare workers, we focus on this. We do know that over 80% of American adults have periodontal disease, which can negatively impact diabetes. We do know that inflammatory processes that start in the mouth can cause issues with inflammation throughout the body. So dentistry, my profession, your profession, those who are listening to this talk, it is essential health care. It's what we're here for, to eliminate pain and disease, to restore function, and also to improve oral health-related quality of life and overall quality of life. As always, it's been an honor to spend some time with you. I wish you well as we move forward through this pandemic, and I will see you soon. So back to you, Gary.
Thank you, Dr. Reznik, for the clinical update. As always, if you have any questions, concerns, or topics for future episodes, please let us know at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. Until we see you again, stay safe and stay informed.